Here we have started, we are now starting actually our electrocardiology session, and it starts with bradyarrhythmias. I like to say a few words about sinus arrhythmia, sick sinus syndrome and AV blocks, because it is bradyarrhythmia is a huge subject. We cannot discuss it in 15 minutes. Let us start. What is sinus arrhythmia? Sinus arrhythmia is characterized by phasic variation in sinus cycle length, during which maximum sinus cycle length minus the minimum sinus cycle length exceeds 120 milliseconds, or the maximum sinus cycle length minus the minimum cycle length divided by the minimum sinus cycle length exceeds 10%. It is arithmetic definition. Most frequent form of arrhythmia considered as normal event in life. PM morphology does not usually vary, and the PR interval exceeds 120 milliseconds and remain unchanged because the focus of the recharge remains relatively fixed within the sinus node. And this is the one strip of ECG which is showing there is increase in QRS complexes rate and some decrease in QRS complexes rate. This is indicates intact vagal tone. It is common in the young, especially those with slower heart rates and after enhanced vagal tone, as for example, following administration of digitalis, morphine or athletic training. It decreases with age or with autonomic dysfunction, that is diabetic neuropathy. It appears in two basic forms. One is respiratory form. The PP interval cyclically shortens during inspiration, primarily as a result of reflex inhibition of vagal tone, and slows during expiration. Breath holding eliminates the variation in cycle length. Another one, non-respiratory sinus arrhythmia, is characterized by phasic variation of the PP interval unrelated to the respiratory cycle and can be a result of digital intoxication. Loss of sinus rhythm variability is a risk factor for sudden cardiac death, so it is not considered as always benign. Usually asymptomatic, occasional palpitation or dizziness may occur if the pauses are excessively long. Marked sinus arrhythmia can produce a sinus pause sufficiently long enough to cause syncope if not accompanied by an escape rhythm. Treatment usually unnecessary. Increase the heart rate by exercise or drug generally abolishes sinus arrhythmia. This is the summary. What is sinus arrhythmia in summary? Sinus arrhythmia of young men and children, respiratory and non-respiratory variation of heart rate. In inspiration rate is higher, variation of heart rate more than 10%. It indicates good autonomic nervous system and good SN node function. This is the ECG, 12-lead ECG of a sinus arrhythmia evidence. What is the differential diagnosis? Frequent premature atrial contractions, second degree AV block, that is Mobis type 1, and type 1 sinoatrial exit block. And next comes sick sinus syndrome. That is a sinus node disease, also known as sick sinus syndrome, comprises a wide spectrum of sinoatrial dysfunctions, ranging from sinus bradycardia, sinoatrial block, sinus arrest to bradycardia tachycardia syndrome. An additional manifestation of sinus node disease is an inadequate chronotropic response to exercise, reported as chronotropic incompetence. Sinus node dysfunction or sick sinus syndrome, what it called? Mode of presentation: inappropriate sinus bradycardia, sinus arrest, sinus pause, sinoatrial exit block, tachycardia bradycardia syndrome, chronic atrial fibrillation, combination of SA and AV conduction disturbances. This is sinus bradycardia. Inappropriate sinus bradycardia. Sinus bradycardia is inappropriate when it usually slows, persistent, does not increase sufficient with exercise. This is sinus pause. The long pause of more than 3 seconds is terminated by a junctional escape complex. You see the arrow, that is the junctional escape complex. This is sinoatrial exit block. This is one of the manifestations of sinus node dysfunction. The long PP intervals representing the pauses are exact multiples of the shorter PP intervals representing basic rhythm. The long pauses should be terminated by another sinus impulse and not by an escape complex. This is the, you see, this is the multiple of 1, 2, 3, 4, 5. 5 QRS short QRS complex, and this sinus pause is the equal to that's 5. This is sinoatrial exit block. And another example, this is multiple of the same remains the same. The sinus pauses remain the same. PP intervals remains the same. This is the 2 PP intervals are equal to 1 long pause. This is another form of sick sinus syndrome, that is tachybrady syndrome. There is sinus pause, top one is multiple, and the irregular intervals, that is top intermittent sinus arrest is apparent with junctional escape beats at irregular intervals. But the lower panel, in the lower panel you can see there is a big sinus pause with a escape rhythm. Etiology, it is a huge etiology, huge. So it is difficult to remember. Mostly it is degenerative, sometimes ischemic heart disease, sometimes myocardial infarction can cause it, cardiomyopathy can cause it, surgery can cause it, and a list of drugs. That is all the antiarrhythmic drugs may be responsible for this. Diagnostic evaluation. The presence of sinus dysfunction is usually diagnosed by cardiac monitoring, which depends on the frequency of symptoms. That is Holter monitor, event recorder, implantable loop recorder, electrophysiological study. Management, pharmacologic management. In patients with extrinsic cause of sinus node dysfunction, treatment should be directed towards the underlying etiology. Drugs known to depress sinus node function can be switched to other agents. Theophylline and beta-adrenergic agonist is used to treat symptomatic bradycardia. Temporary pacing for bradycardia attributable to sinus node disease. Temporary pacemaker is a breathing you can call an instrument until he implanted a permanent pacemaker to resolve pressure. What is the recommendation? This is the ESC recommendation of 2021. In patients with sinus node disease and a DDD pacemaker, minimization of unnecessary ventricular pacing through programming is required. All are class 1 indication and level of evidence 1 and B. ESC recommendation in patients with sinus node disease, a DD pacemaker, minimization of unnecessary ventricular pacing through programming is recommended. Pacing is indicated sinus node dysfunction when symptoms can clearly be attributable to bradyarrhythmias. Pacing is indicated in symptomatic patients with bradycardia tachycardia syndrome form of sinus node disorder in order to correct bradyarrhythmias and enable pharmacological treatment unless ablation of the tachyarrhythmia is preferred. Now class, the next recommendation 2A and 2B. In patients who present chronotypic incompetence and have clear symptoms during exercise, DDD with and rate responsive pacing should be considered. This is 2A classification recommendation class. Atrial fibrillation ablation should be considered as a strategy to avoid pacemaker implantation in patients with AF-rated bradycardia or symptomatic pre-autonomic pauses after AF conversion, taking into account the clinical situation. This is 2A also. In patients with bradycardia tachycardia variant of sinus node dysfunction, programming of atrial ATP may be considered. We can do it with pacemakers. Recommendation 2B and 3. In patients with syncope, cardiac pacing may be considered to reduce recurrent syncope when asymptotic pauses more than 6 seconds due to sinus arrest is documented. This is 2B class. Pacing may be considered sinus node dysfunction when symptoms are likely to be due to bradyarrhythmias when the evidence is not conclusive, and evidence 3 is not required. Pacing is sinus node dysfunction. What is the summary? In view of this data, DDDR is the pacing mode of first choice in sinus node dysfunction. Unnecessary RV pacing should be systematically avoided in patients with sinus node disease because it may cause atrial fibrillation and deterioration of heart failure, particularly if systolic function is impaired or borderline. This can be achieved by programming of the AV interval and using specific algorithms for minimizing RV pacing. Programming an excessively long AV interval to avoid RV pacing in patients with prolonged AV conduction may be disadvantageous from a hemodynamic point of view by causing diastolic mitral regurgitation, which may lead to symptoms and or atrial fibrillation. Atrioventricular block. Now, there are 3 types of atrioventricular blocks: first degree, second degree and third degree atrioventricular block. We know all. First degree, the PR interval prolonged 200 milliseconds, every PS followed by QRS, marked first degree AV block PR interval more than 300 milliseconds. This is the first degree evidence of upper panel is normal, upper panel is little prolonged PR interval, but the lower panel is marked longer PR interval. AV block, that is second degree, and Mobius type 1, we call it sometimes Wenckebach phenomena. Progressive prolongation of the PR interval culminating in a non-conducted PS. The PR interval is longest immediately before the drop beat. The PR interval is shortest immediately after the drop beat. The PR interval progressively shortens with each beat of the cycle. RR interval progressively shortens. Group beating pattern, the QRS component may be narrow or wide, but are typically narrow. This is, you can see in the upper panel, this P wave followed by QRS, this P wave is not followed by QRS. Next PR interval is shortened. Next PR interval a little longer, next PR interval a little longer, then PR interval P is not conducted to the ventricle. And this is also the same. This P is not conducted. Mechanism of type 1. Mobius is usually due to irreversible conduction block at the level of the AV node. Malfunctioning AV node cells tend to progressively fatigue until they fail to conduct an impulse. This is different to cells of the Purkinje system, which tend to fail suddenly and unexpectedly. The AV block, secondary Mobius type 2. Two or more consecutive PFs are conducted, only single PFs are blocked. The PR interval remains constant. The PR interval surrounding the drop beats is an exact multiple of the preceding RR interval. Patients typically have wide QRS compression due to pre-existing bundle branch block. This is the evidence of Mobius type 2 AV block. This P wave is not conducted, PR interval is okay, this P wave is not conducted, these three are conducted, then one is not conducted, and PR interval remains almost same, equal. Mechanism. In around 75% of cases, the conduction block is located distal to the bundle of His, producing broad QRS complexes. In the remaining 25% cases, the conduction block is located within the bundle of itself, producing narrow QRS complexes. Mobius type 2 is more likely to be due to a structural damage to the conduction system, that is infarction, fibrosis, necrosis, etc. Advanced second degree AV block. Advanced or high grade AV block is a form of second degree AV block where two or more consecutive PFs are not conducted, as in 3:1, 4:1, 5:1 AV block. A twist-on AV block is also included as a form of advanced second degree AV block because only single PF is conducted. The QRS complexes may be narrow and wide depending on upon the site of the block. Unlike third degree AV block, there is still some relationship between the PFs and the QRS complexes. This is the high degree, second degree AV block. It is not complete heart block, but difficult to ascertain from this ECG only, surface ECG. In the upper panel, you can see the upper panel, there is evidence of ST elevation in 2-3 AVF. It may be because of inferior wall MI. Third degree or complete AV block. The PFs and QRS complexes are completely dissociated. The ventricular rate should be slower than the atrial rate and should be